it seems like over the last 20 years I've been watching you guys operate, we went from nothing pre-op, just use our fingers, then everybody needs an ultrasound. And it seems like these days, lots of people are getting CT with contrast, something I call the Randolph effect. What sort of pre-op imaging, how do you decide on an average case like this, Mark, or whether you want a CT or ultrasound? How do you make that decision?
Thanks for the question, Mike. I do agree with Eric that biopsying that lateral neck lymph node would be important for surgical planning. And for patients who have either bulky thyroid disease, which in this case it's not particularly bulky, or lateral neck disease, I typically do go ahead and get a CT neck and chest. I don't see a lot of downsides to it. It also helps us sort of map the surgery a little bit better, make sure we know exactly where the lymph nodes are. Also, because once you start to have lateral neck lymphadenopathy, and this patient may or may not have central neck too, you want to make sure there's no lower central compartment lymphadenopathy, sort of in the border of the superior mediastinum, which you could otherwise miss on an ultrasound, which may be better seen with CT. Certainly, rarely patients can have retropharyngeal lymphadenopathy, which may not be seen well with an ultrasound. So I think those are some of the areas where CT imaging, not only for mapping, but can also pick up a few areas in patients with a little bit more advanced disease, pick up a few areas of disease that you wouldn't otherwise see on the ultrasound.